The following podcast is part of a certified educational activity titled Improving Outcomes in Patients with Molecularly Altered NSCLC through Broad Implementation of Precision Testing and Treatment. Latest evidence and practical guidance in the context of a changing targeted therapy landscape. Access the entire activity and complete the post-test at peerview.com/NPG860. Downloadable slides and practice aids are also available.
Hello and welcome to this educational activity focused on the expanding role of precision testing and treatment of non-small cell lung cancer. I'm Dr. Alexander Drillon, the acting chief of the Early Drug Development Service at Memorial Sloan Kettering Cancer Center in New York. I'm joined today by Dr. Benjamin Levy, who is the clinical director of medical oncology at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Thanks for being here, Ben.
Thanks for having me, Alex.
So I thought we'd start today by talking about strategies for molecular profiling in lung cancer. And maybe we'll begin with the number of different potentially actionable alterations that we've identified in the last couple of years even.
Yeah, I think it's never been a more critical time to consider molecular profiling for patients with lung cancer. Clearly, the movement has been, this is not a one-size-fits-all model. We need to discover underlying genomic underpinnings to drive treatment decisions. And, importantly, for every patient, we need to think about clinical and pathological stage first for patients. Look at their overall performance status, and then obviously start to classify their non-small cell lung cancer, not only histologically from an immunohistochemical standpoint, but then looking at molecular features. There are multiple steps involved in this, and we're still trying to better define the best practices for this. It's evolving. But clearly, first, discerning small cell from non-small cell lung cancer is critical. The chemotherapy regimens are different for the two. And then within non-small cell, determining subtype, squamous cell versus adenocarcinoma, and large cell. And then, as you mentioned in your intro, really looking at the genetic underpinnings, looking at the molecular features of the tumor. So I think we have to remember that PD-L1 testing also needs to be done in conjunction, but we need to prioritize tissue, and molecular testing is critical for determining what the right treatment for the patient is. And we've learned in non-small cell lung cancer, again, there are multiple actionable mutations. We can define molecular subsets, and based on that molecular subset, wed that patient to a particular targeted therapy. So I think that's kind of a high-level overview of molecular testing and critical for our patients with non-small cell lung cancer.
And I think it's important to point out that there are many different assays that you can use to interrogate someone's tumor for one of these drivers. And so most commonly we'll use a DNA-based assay, right? And given that there's a longer gene list than there was in the past when we did single gene testing, then obviously something that's more cost-effective and efficient would be to do a comprehensive panel that gets everything that you want. However, given that a lot of these are DNA, we do need to remember that in patients where your gut feel is that something's sitting there and you send off a next-gen DNA-based assay and nothing comes back, that there is some data showing that if you then do a pass looking at RNA, that you might detect one or more of these different fusions or met exon 14.
Yeah, it's critical. It really is. And just to reinforce what you just said, I think comprehensive genomic profiling is the way to go. This single gene sequential testing really needs to be done away. And the importance of this, identifying a genetic alteration that we can wed to targeted therapy, we see certainly in the EGFR space with osimertinib response rates as high as 70%. And the list goes on now. ALK, ROS, BRAF V600E, HER2, RET, NTRK, all of these genetic alterations can be wedded to targeted therapies that then can lead to improved outcomes for our patients and dare I say, better quality of life. I mean, that's really important.
Oh, absolutely. And the vast majority of our discussion today will really tease out what the activity and safety of these new strategies are. But backing up a little bit and talking about other tests that could be done, I'm sure there are patients where it may be challenging to get a biopsy in the clinic. And can you talk about a complementary strategy that you might use for those situations?
I think in the past 5 to 10 years, we've really begun to understand the power of plasma and liquid biopsies. These are, who would have thought even 5-10 years ago, that this was possible to be able to take 10 cc's of blood, look at circulating tumor DNA, not circulating tumor cells, but circulating tumor DNA, and be able to do genetic interrogation off that platform and have very similar concordance with tissue testing from the same patient. So plasma is reliable. I think what we know is that stage 4 non-small cell lung cancer patients, roughly 60 to 70% of patients will shed circulating tumor DNA. That shed is higher depending on metastatic load. If the patient has liver metastases or bone metastases, they're more likely to shed ctDNA. And what we know now is obviously we have multiple platforms that can capture circulating tumor DNA and do the genetic interrogation, and that is reliable. I think that it's important. The concordance between plasma and tissue is quite high, so that a positive result is essentially ruling in the results. We've had a large body of data recently published looking at more than 500 patients that they did both plasma and tissue, and they show high positive predictive value of identifying alterations in the plasma. And this is not just with EGFR. If you find an EGFR, it's going to be in the tissue, but this is with other alterations as well: BRAF, ALK and ROS, KRAS, mid-exon 14 skipping, again suggesting that if you find an alteration in plasma, that essentially rules in their genotype, and you can use that information to drive treatment decisions. I think one of the critical questions that's being asked about plasma is, when should you do it? We do tissue testing on all of our patients, given all of the reasons that we just went over, finding these molecular subsets that we can wed to targeted therapy. The question is, when should plasma play a role? And we've got a couple of different trials now. One of the trials, Charu Agarwal, is looking at patients in which they did both plasma and tissue. And they found that essentially in these patients, if you layered in the plasma with the tissue result, you enhanced your capture of alterations. And it really sort of changed the algorithm. Every patient who is treatment naive, who has a tissue biopsy, there should be a consideration to do a parallel plasma test. Based on the data, I think we've seen that ordering plasma in conjunction with tissue will increase your chances of identifying an actionable mutation. A negative plasma test tells you nothing, essentially, because the false negative rate is 30%. But if it's positive, you can act on that, and you can act on it quickly. And one thing we also didn't mention is the turnaround time of plasma. I mean, this is a test that you can order in your office, and you can get a result within 7 business days, 7 to 10 business days. So it's pretty remarkable.
Maybe one thing to point out is there are also certain events that you may not always pick up on plasma. Like if someone progresses maybe on a tyrosine kinase inhibitor and their cancer undergoes morphologic transformation, a small cell, it's not something that you may typically pick up on a liquid biopsy test. So let's first start with probably the most popular gene in non-small cell lung cancer. That's a driver oncogene, and these are EGFR mutations. Ben, are all EGFR mutations the same?
Yeah, the short answer is no. I think we've learned a lot about EGFR biology in the past 5 to 10 years. EGFR has been the leading edge of precision medicine in lung cancer. The 2 most common sensitizing mutations that we see are exon 19 and the L858R. We know from multiple data sets that these mutations predict sensitivity to tyrosine kinase inhibitors. But then there are other uncommon mutations that we'll talk about that may or may not predict sensitivity in exon 18. And then exon 20 EGFR mutations, we're still trying to learn about these. Not all exon 20 mutations are the same. Some exon 20 mutations may predict sensitivity to TKIs. The majority of them do not.
Absolutely, but maybe let's start with a canonical exon 19 and L858R. What are the current strategies, and what does the trial data tell us about the frontline setting in which TKI to use?
I think we've come a long way. And what we've seen in multiple studies is that first or second generation TKIs outperform chemotherapy in terms of response rate, in terms of progression-free survival, not in terms of overall survival from the first trials, but probably due to the heavy crossover.
That's right.
But perhaps underrepresented in the literature, and just as important, is quality of life. I think that all of these studies initially show that delivering frontline TKI improved outcomes, response rate, PFS, and quality of life. And that really changed the way we thought about treating EGFR and really put EGFR testing on the map. I think more recently we've had some head-to-head comparisons between next-generation TKIs and older TKIs. The first is the Archer 1050 study. This was a trial looking at patients with sensitizing activating mutations, advanced stage patients, randomized 1-to-1 to gefitinib versus dacomitinib. We saw an improvement in progression-free survival with this next-generation TKI versus gefitinib. We saw also an improvement in overall survival. So I think that really, this was the first trial we saw where you compared two TKIs where we saw an improvement in outcomes between the two arms. I think importantly, however, we have to look at toxicity of dacomitinib, and unfortunately, there was a high rate of diarrhea, paronychia, stomatitis. So I think that the drug, while outperforming first-generation TKI, probably due to its toxicity, has very little uptake right now.
Yeah, quality of life, in my mind, can tend to go the other way.
Yeah.
And one other thing about the trial is that it didn't include patients with brain
mets,
metastases.
right, yeah.
But are there other pills that were also tested in the same fashion?
Yeah, I think we have newer data with better tolerated next-generation TKIs. Of course, the Flora trial was practice-changing. This was a large phase 3 trial, more than 600 patients with activating mutations randomized 1-to-1 to osimertinib or the standard of care, which is erlotinib, gefitinib. There was an improvement in PFS. The improvement was for patients with both brain metastases, which were allowed in the trial, and those without brain metastases. And then perhaps most important, what we like to see, that coveted space between two curves here. We saw that. We saw an OS advantage in Flora. And the drug is exceptionally well tolerated in the context of other drugs we have seen. We don't see that rash. We don't see diarrhea like we do with first-generation TKIs. And I think because of Flora, really based on three things, really, its OS benefit, its CNS penetration, showing a benefit with osimertinib versus first-generation TKI, and then its safety profile. The low rates of AEs in the osimertinib arm, it really changed the calculus for us, I think, and it moved osimertinib, which was first thought to be a T790M-directed therapy delivered upon EGFR first-generation TKI resistance. Now moving it into the front line, I think has changed the game for us.
Yeah, so definitely checked all of the boxes. But I think going back to the very beginning of this discussion, we talked about how not all EGFR mutations are the same. And certainly we know that when we do these tests that sometimes you might get an uncommon mutation that comes back. Are there strategies for dealing with those cases?
Yeah, I think that there are probably two strategies that can be implemented for uncommon mutations. One is osimertinib. We've got data now that osimertinib is active in uncommon EGFR mutations. And we also have afatinib. Afatinib has also been shown recently, largest group of uncommon mutations, that afatinib does elicit meaningful responses.
And so once patients have had an upfront TKI, what do we know about how these cancers evade targeted therapy eventually, acquired resistance?
Yeah, acquired resistance. We knew a lot about acquired resistance in the first-generation TKI. When patients were on erlotinib or gefitinib, we'd really ironed out some of the mechanisms of resistance in these patients. And roughly 50 to 60% of these patients had a T790M mutation, and that's where osimertinib started. But we also had MET amplification, HER2, and then importantly, small cell transformation that we saw. We had a nice little pie graph and parsed out mechanisms of resistance post first generation TKI. I think now that osimertinib has moved frontline, I think we're still trying to learn about mechanisms of resistance to osimertinib.
Absolutely.
And that's important to inform treatment decisions and trial design. We, of course, have identified C797S as a potential mechanism of resistance. We look at MET amplification as a mechanism of resistance. We're seeing KRAS mutations popping up from time to time, BRAF mutations popping up as mechanisms of resistance. I think the largest body of data we have for mechanisms of resistance post first-line osimertinib has been in plasma. So I think we just have a nascent understanding of this right now. We're just at the ground floor, and it'll be important to better define and characterize tumor biology post-osimertinib as we move forward.
Absolutely, and sometimes you even see fusions pop up, like RED or ALK, things we're used to seeing in isolation pop up in the EGFR context. What do we know about combination therapies for EGFR mutant lung cancers?
Yeah, I think it makes a lot of sense now that TKIs have defined their role in the EGFR space, that then we add certain agents up front. You know, there's controversy. Should you add agents up front or should you delve into the resistant setting? And they're both going on, but I think some of the data we have with bevacizumab continues to emerge, and what we've seen in a couple of studies from Asia is that adding bevacizumab to first-generation TKI does improve progression-free survival. And then we have Relay, which is a randomized study to erlotinib versus erlotinib plus ramucirumab, showing a robust benefit in progression-free survival. And I will just say that ramucirumab plus erlotinib, the PFS is around 19.4 months, which is not that far off from what osimertinib provides. Now, so I think the anti-angiogenesis story is still beginning to, the story still is evolving, and we'll learn more. I think there's a cooperative group trial looking at osimertinib plus ramucirumab versus osimertinib alone. So I think we'll learn more as we move forward.
On May 29, 2020, the FDA approved ramucirumab in combination with erlotinib for the first-line treatment of metastatic EGFR mutation-positive NSCLC based on efficacy data from the Relay trial.
And how about adding chemotherapy to TKI?
What we've learned from a Japanese study and an Indian study is essentially if you add chemotherapy to a first-generation TKI and compare it to a first-generation TKI alone in EGFR mutant lung cancer patients, you do witness marked improvement in overall survival.
Yeah.
And that maybe speaks to tumor heterogeneity up front and knocking out the clones that aren't sensitive to the TKI. I think what we don't know is whether the same trend will hold true if we use osimertinib. Remember, the data we have with chemo is with first-generation TKI, and we don't know if chemo added to third-generation TKI compared to third-generation TKI alone will do anything. FLAURA2 is a trial that will look at this. So that's exciting. I think that we'll enroll quickly and we'll have our answers soon. So Alex, you were talking earlier about how not all EGFR mutations are the same, and exon 20 has been this EGFR mutation that we've had a hard time getting to in drugging. Do you want to talk a little bit about exon 20?
Yeah, for sure. So it has been a very recalcitrant subtype of EGFR mutations and has a lot of parallels actually with HER2 mutations that are also insertions deletions, and we'll look at that later on. But the thing about these mutations is that designing drugs tends to be challenging because these kinase domain mutants sort of behave similarly to wild type. So there's a lower therapeutic window here, and that'll inform what we're seeing in terms of side effects. But basically, there are a few different drugs that have been explored. There's the drug poziotinib, which is an inhibitor of the ERBB family. And we've certainly seen responses in anywhere from 15 to 30% of cases, given the updated data. Beyond that, there are drugs like TAK-788. And in the XCLAIM extension cohort, we actually saw a very encouraging response rate of north of 40%. So why don't we pivot now and talk about fusions? And we'll start with one of the most common ones, ALK, that occurs in up to 4% of patients. What do we know about targeted therapy?
Yeah, it's become a crowded space for ALK fusions. We started out with crizotinib, and then we've moved forward now with multiple other agents that are FDA approved. We have ceritinib, alectinib, brigatinib, and lorlatinib. And we have other ALK drugs that aren't approved, ensartinib and entrectinib. Crowded space for a small niche, but nevertheless, it's embarrassment of riches for us. I think that while we started out with crizotinib as the standard of care for patients with ALK rearrangements, we really have now moved more towards next generation ALK-directed therapy, similar to the EGFR story. And we have really two trials that have shown that next generation ALK drugs, either alectinib or brigatinib, have outperformed crizotinib. So the first trial obviously is ALEX, randomized 1-to-1 to alectinib versus crizotinib, showing an improvement in response rate, an improvement in intracranial response rate, improvement in PFS. And interestingly, the median PFS in the alectinib arm is 34 months. That's PFS, not OS. That's close to 3 years. So I think that that trial really altered the therapeutic paradigm for patients with ALK rearranged lung cancer. The safety profile was reasonable with alectinib compared to crizotinib. I think we see some increases in LFTs, perhaps some nausea, some bilirubin elevations, but overall a real win for ALK-rearranged lung cancer patients. More recently, we've got the ALTA-1 data, very similar design, patients randomized to brigatinib, another next-generation ALK-directed therapy, versus crizotinib, showing an improvement in PFS, a hazard ratio of 0.49, a proclivity for activity in the brain compared to crizotinib. And so I think both of these have been a win for patients with ALK-rearranged lung cancer. Certainly my standard of care for patients that are ALK-rearranged is alectinib.
On May 22, 2020, brigatinib received FDA approval for first-line treatment of ALK-positive NSCLC based on results from the ALTA-1L trial, which showed a progression-free survival hazard ratio of 0.49, an objective response rate of 74%, and an intracranial response rate of 78%.
I think probably one of the most important things to talk about with patients who are ALK-rearranged is that they do have a propensity to metastasize to the brain. And I think the old school way of thinking is when patients come in with brain metastases, these patients should be referred to radiation oncology. And this gets back to how important it is to do molecular testing, because if a patient has an ALK rearrangement and they do have brain metastases, the response rates to alectinib and brigatinib in the brain are north of 70%, and it really circumvents the need, I think, initially for a radiation oncologist. And I don't know if you have any different thoughts about this or if this has changed your practice pattern, but it's been surprising how well these drugs really are, how active they are in the CNS.
Yeah, I agree 100%. And alectinib is also my preferred TKI up front. And really, we're seeing a parallel to what we saw with osimertinib. Good drug in the brain, addresses resistance, and we're reaping the benefits in the frontline setting. But let's talk a little bit about resistance. What do we know about how these drugs develop on-target resistance to target TKIs, the early gen TKIs?
I think that we've got a lot of data now emerging with resistant patterns post-alectinib. The one that is really front and center is the G1202R, Egfr mutation, quite prevalent post-alectinib based on the data we have, and that's really one where we're trying to learn how to best target.
And what we know from data with next-generation drugs like lorlatinib, which can work very well against these kinase domain mutations, is that there's just a paper showing that in patients whose cancers actually harbor these mutations, the response rate seems to be higher than in patients that don't. So in a sense, it may be a way of selecting patients who are most likely to benefit from this therapy, but I would argue that even in the absence of molecular profiling, the overall profile of the drug with a response rate of about north of 40%, still pretty reasonable to just go ahead and start.
ROS1, yet another fusion that's relevant in advanced non-small cell lung cancer. The data, of course, probably starts with crizotinib, but we've got newer agents that are coming down. Maybe you can just walk me through the movement that's happening within ROS right now.
Absolutely. So as you said, the first agent to demonstrate activity was crizotinib. Interestingly, also in the Profile 1001 trial, you had an excellent response rate and, interestingly, a median PFS that was about 19 months, so much longer than we saw with ALK fusions for crizotinib. So it says something biologically about these tumors. But as you intimated, there are now 2 FDA-approved TKIs. The second one is entrectinib for ROS1 fusion-positive lung cancers, and actually data on ceritinib, which is in the NCCN guidelines but not FDA-approved. Very briefly, the data on ceritinib was from a phase 2 South Korean trial, where also we saw very good response rates and progression-free survival that were comparable actually to what we saw with crizotinib. And then finally, moving back to entrectinib, which is different from the other drugs in that it's a multi-kinase inhibitor that also inhibits TRAC. And it was designed to have meaningful activity in the central nervous system, something that, at least with crizotinib, we were worried about given the data in ALK. So what are we seeing? With the entrectinib data, there was a pooled analysis of 3 different trials showing, again, a high response rate and a median progression-free survival that in the overall population wasn't very different from crizotinib. However, if you take a deep dive and look at things like duration of response, then you are seeing the numbers get up into about the 25-month range. So I think that even though the high-level data seems similar for entrectinib and crizotinib, if I had someone walk in the door in clinic, today I tend to favor entrectinib just because you might get the activity of the drug in the CNS to prevent brain metastases, but hopefully also lengthen progression-free survival.
Yeah, and as you mentioned, I think the pooled analysis from the Star Trek data, they did show in the 50-something odd patients that there was a meaningful response in the brain.
Correct.
And I don't think we've seen that with, at least reported data with crizotinib.
Yeah, you're absolutely right. The Profile 1001 trial reported 0 patients with brain metastases. So there's much more of a wealth of data on CNS activity with entrectinib.
Okay, so you've got crizotinib, ceritinib, and entrectinib. Do you ever revert back to criz at any point? Not after, but you said entrectinib is sort of your go-to solely based on the CNS activity, or are there patients that you would still use crizotinib frontline for your ROS1 patients?
I think in general, as long as there are no issues surrounding tolerability, I would just use entrectinib for all of my patients that walk in the door. But it's interesting, the question as to what to use next, and that's really informed by resistance patterns that we see with the early gen TKIs. Obviously, the most data that we have is with crizotinib, but as we've talked about with ALK, you can see these cancers acquire ROS1 kinase domain mutations, like the G2032R solvent front mutation, which is paralogous to the ALK G1202R. And fortunately, there are next generation agents that have been explored after patients fail a first generation pill. The first one we'll talk about is lorlatinib, which we've heard about already, also a ROS1 inhibitor. The drug does have very good CNS activity and has a reported response rate in about the 30 to 40% range after patients fail crizotinib or another TKI. The one thing though about lorlatinib is that if you look at patients that have the G2032R solvent front mutation, you're not really seeing meaningful responses there. You are seeing responses with other kinase domain mutations, but at least for that subset of patients, you don't get as much activity as we had hoped to see. Thankfully, there is another drug called repotrectinib, or TPX0005, which in contrast to lorlatinib was really meaningfully designed to hit the solvent front mutations and the other kinase domain mutations. And in that data set, a drug that also has good CNS activity, we are in contrast seeing responses in cancers that harbor solvent front mutations in the ROS1 kinase domain.
It's exciting. So how do you sequence this out? What do you do in your clinical practice?
I don't think we have a really good algorithm yet, and I think more data will inform us. But what I do is I start with a first-gen TKI like entrectinib or crizotinib. When they're resistant, I transition to lorlatinib or repotrectinib. But it brings up the question, can you then move these next-gen agents into the first-line space, as we've spoken about for EGFR and ALK? And certainly both programs have actually looked at ROS1 TKI-naive patients. Interestingly, we're seeing high response rates, but what you really want is a PFS readout, and we don't have mature data yet.
Well, it'd be interesting to see if it, as you said, mirrors the ALK and EGFR where drugs are moving up rather than being waiting for second or third line. It's an incredible time in precision medicine for lung cancer. So let's stay on the fusions, and really, you've obviously championed the therapeutic landscape for the next fusion, NTRK fusions. You know, this is a different type of fusion because it can be found in multiple tumor types, and we have a basket trial that has landed NTRK fusions on the map and put that into what we need to do up front and test these patients. You want to talk a little bit about the evolution of NTRK and essentially the NTRK drugs that are currently coming or currently approved or coming down the pike soon?
As you mentioned, it's really championed the basket trial strategy because the way I look at the frequency of these TRK fusions, they're very common in 4 rare malignancies like secretory carcinoma of the salivary gland or breast, congenital fibrosarcoma, and congenital mesoblastic nephroma. But they're also, the second bucket is a bucket where you're seeing them with much lower frequencies in more common cancers like lung cancer. So if you prospectively sequence lung cancers, you'll see that TRK fusions are found in about 0.2% of cases, recognizing that you're sequencing for a bunch of other things at the same time. But the top line data with the first generation TRK inhibitors which are larotrectinib or entrectinib, which we've already talked about for ROS1, is that you're seeing response. And this is across cancer types. So many of those cancers went onto the basket trial, regardless of what they looked like under the microscope, as long as they had the TRAC fusion of interest. And the neat thing about the program is that it not only got both of these drugs FDA approved and actually approved in other regulatory environments, but for the first time, looking at the larotrectinib program, about a third of those cases were pediatric cases that went on. And we've leveraged a pediatric population to help get a drug approved by regulatory authorities around the world. The other thing is that if you look very closely at the label, there were cases on the larotrectinib trial of kids that had really bulky tumors that weren't amenable to local therapy. They got target therapy, tumor shrank nicely. They got a limb-sparing surgery and a complete pathologic response. So actually the label allows you to give a TRAC inhibitor in a neoadjuvant fashion for patients with locally advanced disease. So a lot of exciting stuff has happened in just the last 2 years.
And just a brief comment on toxicity of these drugs, because they have some interesting on-target side effects that we need to be mindful of.
That's true, and that's because the TRAC pathway plays a very critical role in nervous system development and maintenance. So things you have to watch out for in your patients, which we're not used to seeing, are things like weight gain, because the TRAC pathway modulates the appetite center. Things like pain flares if patients momentarily come off these drugs because of, again, rewiring of your threshold for feeling pain. Patients can get dizzy. They'll say that they get out of a car and they feel lightheaded, and that's because the TRAC pathway can control balance. And also in line with these neurologic on-target side effects, sometimes you can see paresthesias that are perioral or like a sunburn-like sensation. But for the most part, I think even though we need to recognize these unique toxicities, these drugs are very well tolerated and are amenable to chronic dosing. What we do know is that similar to ALK and ROS1, that resistance can occur. And again, on-target resistance happens when you have these kinase domain mutations that either involve the solvent front, the XDFG motif, or the gatekeeper. Thankfully, there now are, believe it or not, second-generation pills that address resistance. The two of these are selitrectinib, or LOXO-195, and repotrectinib, which we've already talked about for ROS1. And both of these drugs were designed to be smaller and fit better into the ATP pocket and address resistance. And we've seen clinical responses reported out for both programs. In fact, the most data that we've seen has been with selitrectinib, or LOXO-195, where about 40 to 50% of cases with gatekeeper kinase domain mutation, solvent front, or XDFGs will respond to therapy. So very exciting times.
It is. I mean, just to take one quick step back about identifying NTRK, these are fusions, not mutations. Correct. And we're going to see some mutations on our NGS reports, and those do not predict efficacy of these drugs.
That's right. So the only situation where you may need to pay attention to mutation is when it pops up on top of a fusion, but not when it's there by itself.
Yeah, incredible story. So let's just finish off the fusions here with RET fusions. Yet another actionable alteration discovered in lung cancer with some really good drugs coming down. Do you want to talk a little bit about the relevance of RET rearrangements in lung cancer and what we can do and what the drugs are showing?
Yeah, sure. Like ROS1 fusions, these are found in up to 1 to 2% of non-small cell lung cancers. And again, you're looking for a fusion. When we didn't have great drugs, we tried older, dirtier drugs called the multikinase inhibitors like cabozantinib, and the results were modest. You know, we saw response rates anywhere from the high 20% to 50%, but these drugs came with a cost, that these drugs resulted in a lot of side effects due to off-target toxicity. So fortunately, in 2017, we saw the emergence or the entry of selective, clean RET inhibitors into the clinic, and there are two major ones. These are selpercatinib or pralsetinib, formerly known as LOXO-292 and BLU-667. But again, these are designed to be clean drugs that hit the target very potently, but also avoid these other kinases that result in off-target toxicity.
On May 8, 2020, the FDA granted accelerated approval of selpercatinib for the treatment of adult patients with metastatic RET fusion-positive NSCLC based on the efficacy results of the Libretto 001 trial.
And what we've seen is that the top-line data is that these drugs can work very well.
Yeah.
Both drugs result in high response rates, north of 60%. That's not just in patients who have had chemotherapy, but also in patients who have had a prior multi-kinase inhibitor. Or even in treatment-naive patients. And last thing I'll say about prior treatment is that some of these patients also got immunotherapy, and it didn't seem to affect the likelihood of response. The one other piece we'll mention is that because these drugs are cleaner, we definitely, in terms of an adverse event profile, are seeing that these drugs are much better tolerated in the clinic compared to the multi-kinase inhibitors.
And having been an investigator participating in one of these drugs, I can tell you, I mean, as you know, it's pretty incredible to see the impact they have not only on tumor shrinkage, but quality of life. We've had several patients coming in and coughing and short of breath, and within 2 weeks of getting these drugs, have marked improvement in their symptoms.
One thing that we should note also is that these drugs, both of them have intracranial activity.
Yeah.
So we've seen CNS metastases, brain metastases shrink nicely with these agents. And we just published a case actually with selpercatinib of a patient of mine with leptomeningeal disease, couldn't get onto the trial, went on an FDA-approved single patient use protocol, and the leptomeningeal disease responded.
Yeah.
So kind of mirroring what we've seen with osimertinib in EGFR mutant lung cancers with leptomeningeal disease.
And what do we do if we have these drugs up front or even in the treatment refractory setting? What do we know about mechanisms of resistance? Are there other drugs that are coming down the pike that may help out with this, similar to, again, the EGFR and ALK story of sequencing TKIs?
Again, we benefit from seeing a lot of parallels with the other fusions. And certainly there's a recent report about these solvent front RET mutations in the G810Rs or other substitutions that have emerged with these selective early generation TKIs. And so thankfully, there are agents being designed to address these solvent front mutations. One of them is a drug called TPX0046 that was presented in abstract fashion previously. So the hope again is that we'll see a sequential TKI paradigm for treatment in the future. All right, Ben, we're done with the fusions, and now we're going to jump back into the mutations, and we're going to begin with BRAF.
Yeah.
What do we know about BRAF mutations in lung cancer?
Yeah, I think this is yet another relevant alteration. It occurs in roughly 3% of patients with advanced non-small cell lung cancer. Similar to the EGFR story, not all BRAF mutations are the same.
Right.
I think the ones that have become front and center and relevant and actionable have been the BRAF V600E mutations, but there are also non-V600E mutations, and the question is how to really target those. And there are ongoing trials looking at targeted therapies and combinations for non-V600E mutations, but it calls back the importance of looking at the molecular report. Not all BRAF mutations are the same. Some are actionable, some aren't. Clearly, the V600E is the one that then can drive a treatment decision with targeted therapy.
And we know that the single agent RAF inhibitors certainly are active in this space with response rates in the order of 30 to 40%.
Yeah.
But is that the best strategy for these tumors?
Yeah, I think what we've learned is that combo strategy with RAF and MEK inhibition is really elicited the most meaningful responses.
Similar to melanoma, right?
Similar to melanoma. I think we've got now data both in second line and treatment refractory patients and in front line, showing a response rate anywhere from 60 to 70% for BRAF V600E, and PFS ranges between the 10 and 11 month mark. There's a lot of questions on whether you should use your targeted therapy first or after treatment. I think my paradigm and my approach to these patients is if you identify it and find it, you should go ahead. That should trigger a targeted therapy decision with dabrafenib and trametinib.
Absolutely, and because of the activity that you mentioned, this combo is actually FDA approved for these patients.
Yeah, I think it's important. One other question that maybe we'll talk about later is the role of, BRAF V600E mutations may be the one genotype that does okay with immunotherapy or immunotherapy combinations. And when you identify this, should you use an immunotherapy or immunotherapy regimen, or a dabrafenib trametinib combination? And I think the jury's still out, but I tend to use targeted therapy first for these patients.
That's my approach as well.
Yeah.
Okay, Ben, moving on to another mutation, let's talk about HER2.
Yeah, another emerging target in which we may have relevant therapies. I think There's been a lot of confusion about HER2 in terms of what's the actual test that drives treatment decision. Is it amplification? Is it overexpression by IHC? Is it mutation sequencing by NGS? And I think importantly, HER2 is overexpressed, amplified, or mutated in a significant fraction of patients with lung cancer. And there's been a lack of correlation between these, between overexpression, amplification, and mutations. I think what we've learned is that mutations may be the right alteration to look at as we move forward. And we have some data on some new emerging drugs that have come out. One of the ones has been trastuzumab, or TDM1. We know trastuzumab from the breast cancer literature. It's an antibody conjugate to a potent microtubule targeting agent. The whole idea is that the antibody binds, it's internalized, and then the microtubule directed agent is delivered to the cell. And we've seen activity with this agent TDM1 in non-small cell cancer cell lines and xenograft models. And the data we have, I think, was presented by your colleague with trastuzumab in patients with HER2 mutated non-small cell lung cancer. And it's a small group of patients, a mix of patients that most of them were treatment refractory or had received it upon second or third line. And this drug did elicit meaningful responses. The response rate was north of 40%, and also there was some nice duration of response in some of these patients. So I think that clearly this is a drug that may have meaningful activity. You were part of the trial. Just toxicity in terms of the things you witnessed in the study?
I think exactly the same toxicity that you would watch out for if you were giving this for breast cancer. So infusion reactions are something that you need to keep an eye on. And then, of course, moving forward serially, you need to watch the heart because a subset of patients may have cardiomyopathies.
The other drug that I think has garnered a lot of attention has been poziotinib, and this does inhibit both EGFR and HER2 exon 20 in vitro. And we've seen activity with poziotinib specifically in the HER2 mutant cohort. The data we have so far, a response rate close to 40% with patients with non-small cell lung cancer harboring HER2 mutations, a PFS around 5 months. We're participating in this trial. I think that this is meaningful activity. I think the challenge with poziotinib has certainly been its toxicity profile. And high rates of rash and diarrhea have been there. I'm not sure if the toxicity, similar to the DACO story, whether it will be dacomitinib for EGFR, whether that will be prohibitive for really receiving wide uptake of the drug, but clearly has some activity in HER2.
Right, and one thing we should point out for the audience is that we're seeing a lot of parallels in terms of therapeutic targeting between EGFR exon 20 insertions, where we have data for poziotinib, and these HER2 mutations. And so other drugs like TAK-788, which we've discussed previously, and other multi-kinase agents like pyrotinib are also being explored in this space. But then again, you still need to keep in mind that the therapeutic window may not be as large as you're seeing with other paradigms like sensitizing EGFR mutations. But I think one thing that's very encouraging is that we are seeing the emergence of the utility of ADCs, or antibody drug conjugates. And certainly the next generation TDM1 we know is trastuzumab deruxtecan, very exciting data in the breast cancer literature. And this is an ADC that has a different payload. It's an exatecan derivative compared to the TDM1 maytansinoid that we talked about earlier. So lots going on in this space.
Yeah, it's exciting to see. And again, yet another emerging biomarker that has relevance, and I think we'll iron out soon the therapeutic window, getting drugs that are active with less side effects. I think that's the whole goal. So Alex, let's move to other relevant alterations. MET exon 14 skipping mutations have also, maybe as prevalent as ALK rearrangements in lung cancer. We need to remember that. We've got certainly some drugs that are newer. We have older drugs that you've recently reported on with crizotinib. So maybe we can start there with crizotinib and the updated analysis, and then move to the newer drugs, tepotinib and capmatinib.
Yeah, so with crizotinib, which is, in addition to being an ALK and ROS1 inhibitor, is also a MET inhibitor. And it's funny because the trial was initially designed to look at MET. and then found its way to the other two genes, and then we're back to MET where we began. But certainly an active drug, it's in the NCCN guidelines with a response rate of about 30%. And if you look at the waterfall plot, most of these patients have disease shrinkage with this agent. But as with ALK and ROS1, it is an earlier generation drug. And there are other type 1 inhibitors that are much more selective for MET, like capmatinib, savolitinib, and tepotinib that are being explored. Beyond that, there is a class of type 2 inhibitors that engage the kinase domain in the inactive state and bind to hydrophobic back pocket that may result in activity after these type 1 drugs fail in select situations. And so an example of a drug like that is cabozantinib. So we've seen a readout of these type 1b inhibitors like tepotinib, savolitinib, and capmatinib. The response rates have sort of bounced around a little bit. So we're seeing response rates anywhere from 30% to north of 60%. And that's been done in various settings, in treatment-naive cases and also those that are pretreated.
On May 6, 2020, capmatinib received FDA approval for the treatment of adult patients with metastatic NSCLC harboring MET exon 14 skipping mutations based on the efficacy findings from the Geometry trial. This is the first approval of a targeted therapy for patients with MET-altered NSCLC.
So very interesting times eventually.
Yeah. And just a brief comment on MET exon 14 skipping mutations versus MET amplification. Is there any correlation between those two, and can you use MET amplification to drive these treatment decisions, or is it really about the mutation, similar to the story we were talking about with HER2?
So I think it's a different story here, because we know that with the early Profile 1001 data that if you have a highly MET amplified cancer, capmatinib or other MET inhibitors can be active. And it is a bit of a Venn diagram, because in about 15 to 20% of cases, you can have both MET exon 14 skipping and a MET amplification. So the way I think of it is that these are both biomarkers of potential activity with MET-directed therapy, and if you find one or the other or both, that would be an actionable situation still.
Yeah, it's good. It's still trying to sort out, again, the alteration that makes most sense for a treatment decision. So this is good clarity.
And thankfully, these trials have also leveraged the fact that we can pick these up sometimes even more easily than fusions if we do a plasma test and have put patients onto the trial with even just a plasma result in the absence of tissue sequencing. Okay, Ben, last mutation of the day, and a mutation that we did not think was druggable until recently. Let's talk about KRAS.
Yeah, so we've got new drugs specifically for KRAS G12C. You know, KRAS is a GTP binding protein. It alternates between the inactive GDP and the active GTP state, and this drug specifically and irreversibly binds to locking into the inactive GDP state. And you know, it's a pretty incredible story because this is probably another 12 to 15% of all non-small cell lung cancer patients that can be drugged with a specific target. It's just widening, or at least lessening the unknown slice of the pie. So the emerging KRAS inhibitor, Amgen 510, evaluated in a small number of patients, 23 patients with KRAS G12C non-small cell lung cancer who had received 2 or more lines of therapy. And what we saw incredibly was response rates north of 40%, which is something that's quite surprising. And I think we're all very excited. Some of these responses that we saw were durable. The drug is fairly well tolerated, certainly in the context of chemotherapy. It's a welcome change. I think we have had other KRAS G12C drugs that are coming down the pike. One is MRTX 849, and we've seen very early on in some preclinical data that the drug has been active. And there are others as well that are certainly going to, I think, make an impact. But clearly a very exciting time. Again, as you mentioned, KRAS thought to be undruggable. You know, we've got now a selective KRAS G12C inhibitor. I think the question for a lot of community providers, what about the non-KRAS G12C? Do these drugs have activity? And I don't know, Alex, if you have any trials or are looking at some of these other types of KRAS to see if there's activity with any of these drugs.
Well, certainly there are some direct inhibitors that are going for other mutations like G13 substitutions. And one of these is a drug that's early in its development, but unlike these other agents that you discussed, targets the active conformation versus the inactive. So we'll see how that pans out. But for non-KRAS G12C mutations, there are other things that could be done, many ongoing trials. A lot of them may give combination therapies that target downstream pathways, and we have seen a few responses. But hopefully we are going to see an increase in these really selective direct inhibitors because, as you pointed out, the toxicity profile is very favorable. KRAS G12C just doesn't exist in the human body except in cancer. And so talking again about a therapeutic window, you're seeing a very favorable safety profile with these drugs.
And just a reminder, as these drugs become available in clinical trials and as they potentially become available and approved by the FDA, I think we need to remind ourselves that some of our patients who are KRAS G12C, who are on chemotherapy, I've had to go back and look who's KRAS G12C because I tested and I didn't put it in the hard drive because I didn't need to. And they went on treatment, and now we have an Amgen 510 trial. Now I have to look back and see, okay, wait, who had a KRAS G12C? So it's a reminder to the clinician that once you ignored that KRAS, and you were right to do that, that it's time to go back and look at the original next generation sequencing report to see what subtype of KRAS they have, so that patients may be eligible for these trials or even drug approvals.
I agree, absolutely. And I think it applies more broadly. Going back to the available menu of targeted therapies every time you have to switch treatment. So one thing we didn't touch on today is there are newer drivers like NRG1 fusions, for example, where there are now several clinical trials looking at the activity of these agents. So like we've said over and over again, exciting times. All right, Ben, getting to the end here, we've discussed a lot of targeted therapies for these actionable drivers, but one thing that might be on the minds of our viewers today is what the utility of immune therapy is for these patients.
I think the data is starting to unfold, and really we've dichotomized the science these days. There's immunotherapy and there's targeted therapy within lung cancer, and there's probably convergence that will happen at some point. It's starting to roll out in clinical trials, but one of the things that we're starting to learn is that immunotherapy, at least as a single agent, may not be beneficial in certain genotypes. We have a retrospective data set looking at a large number of patients and looking at the role of single agent immunotherapy for specific genotypes. And not surprisingly, immunotherapy is not that active as a single agent, at least in the EGFR and the ALK patients, even in the ROS and perhaps HER2 patients. But median PFS of single-agent immunotherapy in these genotypes ranges anywhere from 3 to 5 months. Again, we have to put this data in context because this data looked at immunotherapy as third or fourth line for many of these patients. But what we have learned, at least in the EGFR and ALK space, single-agent immunotherapy usually does not elicit meaningful responses or improvement in outcome. I think the jury is still out, however, about the role of immunotherapy in combination with chemotherapy for these genotypes. But at least as single agent, it's hard to believe that patients would derive a meaningful benefit as a second or third line. We have some prospective data as well, looking at the role of single-agent immunotherapy in treatment-naive EGFR-positive patients. This was a small trial. It took patients that were EGFR positive and had a PD-L1 expression of greater than 1%. And instead of giving them a TKI, the trial mandated that they receive single-agent pembrolizumab. So it's asking the question, essentially, how does single-agent immunotherapy do for EGFR patients who do also express PD-L1? The planned enrollment for the study was 25 patients, but only 11 patients enrolled. The trial was stopped due to futility, which I'll talk about. Of the 11 patients, 8 patients had a PD-L1 expression greater than 50%. Incredibly, patients, the majority of which had a high PD-L1 expression greater than 50%, who received single-agent pembro, the response rate was 0. The one responder from that trial ended up not having an EGFR mutation. So clearly there are efficacy concerns, but there were also some toxicity concerns too for patients who then went on to receive TKI. There was a significant rate of adverse events for the sequencing strategy of getting a immunotherapy first followed by TKI. So I think because of this, it really prioritizes the importance of genotyping your patient. Patients who are EGFR positive, if you start them on immunotherapy and then you find out that they're EGFR positive and then you sequence them to a TKI, there's a real chance for toxicity.
Right.
And so I think it just calls in, again, the importance of rapidly genotyping your patients so that, one, you can deliver the best therapy to patients, and two, you can avoid toxicity. And I don't know if you've had any experience with this sequencing of immunotherapy followed by TKI and what can happen here, but the data would suggest a pneumonitis rate close to 15% for these patients.
I think we've had a very parallel experience, and this is not only in EGFR. We've seen published reports of crizotinib, for example, after immune therapy for patients with an ALK fusion in their cancer, where you see higher rates of transaminitis. And I think across the board, even if we look at newer investigational therapies, we do get the sense that there may be a heightened level of toxicity after an immune checkpoint inhibitor when someone gets a TKI.
So Alex, we've talked a lot about the relevance of all these actionable mutations and the importance of precision medicine in lung cancer, and it's probably a good idea just to go back where we started, which is the importance of molecular testing. Maybe just some key bullet points to take home for both academic and community oncologists to say, how do we best optimize molecular testing? What are best practices? And how do we carry this out in the academic world, but also out in the real world in the community?
I think in terms of choosing best practices, one of the most critical issues is selecting the best test.
Yeah.
And that obviously needs to come with the knowledge of the menu of different actionable drivers and making sure that the test that you choose is well poised to interrogate these different genomic signatures. I'll say that many assays might actually have a gene list, and it might look like you have the gene of interest on the list, but it may not be good at picking up things like MET exon 14 splice site alterations, which are very heterogeneous, or even fusion. Some of them are very hard to capture on DNA-based assays. So when in doubt, I think you need to talk to your pathologist, talk to your molecular diagnostics person if you have one in-house, and make sure that you very thoughtfully select a good assay for your patients.
Yeah, I would say on top of that, again, just to pitch the idea for consideration of plasma on top of selecting your best strategy for a tissue standpoint, I think is critical, because not all testing platforms are the same. But I think layering in a plasma test for patients is critical. I think, again, we've got good data now from Chowdhury Agrawal and good data from the NILE prospectively, and a data set called NILE, suggesting again that when we add plasma to the tissue testing, we increase our capture rate of potential actionable mutations. And so I think my message here is that everyone who's treatment naive should be considered for a plasma test. And similar to tissue testing, there are different plasma platforms out there. And I think you have to be selective on which ones you choose. But I think it's really important that we consider that. One other thing maybe we didn't talk about in the beginning, but we've certainly layered in each of these genotype sections, is the role of retesting upon resistance. And is that the message for providers out there, that patients that are on a targeted therapy who develop resistance or progression, we should be biopsying these patients? And if so, should it be tissue, should it be plasma, should it be both? I think that's one of the main questions I get is, well, I did it up front. Is there any role to doing it again for patients with specific genotypes?
And I think the answer to that is that there is a role. And we certainly know that for each of the different genes that we discussed, there are next generation therapies. And we know that the activity of some of these combinations or single agent TKIs is really dependent on what the genomic signature looks like on progression. So in my mind, if you don't run into issues with payer coverage and are able to do either plasma, tissue, or both, then it could certainly open up treatment options for your patients. And as we move into the future, if more of these next generation therapies are approved, I can see how it'll be easier to get molecular profiling covered at the onset of resistance.
Yeah. One more question, and I'll layer in my insight, is just, how successful we really are at tissue testing. Is this a real challenge? This is the biggest challenge I hear, going back to the upfront testing. We want to select the right platform. We want it to be comprehensive. We want it to identify alterations that include fusions, perhaps with an RNA platform as well. But how often is tissue just not enough? And is this a real barrier at your institution and one that you see out in the community?
Definitely, there are situations where tissue is the issue and you can't get enough of it. I think one thing we haven't talked about is the concept of tissue stewardship and the dialogue between the medical oncologist and the pulmonologist, the interventional radiologist, or the surgeon, and telling them that if safe and feasible, acquire as much tissue as you can to maximize the likelihood of getting enough DNA for an assay. But it's true, there are situations where a patient may be too frail to undergo a biopsy, or it's just maybe in bone and there's not a soft tissue component. And this is why complementary tests like plasma, those things are very critical.
Yeah.
We're at the end of our discussion today, Ben, and this has been really great. And I think we'll maybe leave our audience today with a couple of final thoughts.
Yeah, I think that it's low-hanging fruit here, but the importance of testing. And we've talked about not just the approved targeted therapies, but the emerging ones. And there's probably more emerging targets than there are approved targets, and it's going to get complicated. And the first point I'll say is, it's critical to do genotyping, and that has to be done with tissue and plasma, probably up front. But I've said this in talks before, leave no gene behind. Do everything you can to try to find a gene that may be able to allow a patient to receive a genotype-directed therapy, which could probably outpace chemotherapy. So I think that that's the first thing that I'll say. The second thing is somewhat similar, which is it's getting really complicated. And having just recertified for my medical oncology boards, I can tell you that it is almost impossible to keep up with everything. So my second call would be, don't be afraid to reach out to an expert and say, I'm a little confused here, what would you do? And partnering with other people in the community who may be disease specific, or even academic folks who are disease specific, to say, look, I have a patient, I'm not really sure what to do with this mutation because the reports are confusing. Yeah. So, testing is one, but not hesitating to reach out to people who may be a little more versed in some of this is really important.
Absolutely. And my final thoughts really go back to the therapeutic angle, that for many of these genes, as you've seen, there are FDA-approved therapies, there are other therapies that are in the NCCN guidelines, and that helps get payer coverage. But beyond that, it's also important to recognize that while clinical trials may scare some patients, that some of these newer agents are very promising and may achieve very high response rates and durable disease control. So certainly keep these in mind when you're considering therapies for your patient. Yeah. And that concludes our discussion for today. Thank you very much, Dr. Levy, for joining us. To those of you watching and listening, I hope you have found the program informative and useful to your practice. Thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NPG860. This activity is supported through independent educational grants from AstraZeneca, Bayer Healthcare Pharmaceuticals Incorporated, Genentech, and Loxo Oncology Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.